Everyone, we are so delighted that you joined us for an evening edition of the LymphaPress Educational Webinar Series. As you are logging on, I hope that you will let us know who's out there in chat. Give us your names, tell us your location. We love knowing that we are covering the United States and often beyond with these wonderful webinars. And let me just do some housekeeping first before I introduce our speaker. This presentation is being recorded. If you registered, whether you attended or not, all registrants will receive a link to the replay. There's so much good information. I got a preview of the slides. They're awesome. So you're going to want to look at it again, and that will be made available. We will send all of you the link after the event. I am Brenda Viola. I am with LymphaPress, and I'm happy to moderate today. You will have questions, and our speaker will have answers. So at the end, we will address all of your questions. Feel free to put them in the Q&A. And without further ado, I get to introduce somebody who I've admired for quite some time. I saw her name as one of the authors of the standard of care for lipedema in the United States. And I said, I've got to meet her. And then last year at the AVLS conference, I was honored to meet her in person. We started connecting, and she was on my wish list of people to have as a presenter in our educational webinar series. If I read her entire bio, we would be here for the entire hour. So I'll just give you some high-level updates. She is coming to us from beautiful Colorado, and Molly Sleigh specializes in the treatment of lipedema, lymphedema, and oncology rehabilitation. She's an adjunct professor in the Department of Occupational Therapy at Rocky Mountain University and an occupational therapist at Centura Health in Colorado Springs. Whether we talk about the standard of care or LANA, her faculty on the American Vein and Lymphatic Society, AVLS, and recently appointed to the Fat Disorders Resource Society, FDRS, which I'm going to get to see her at FDRS next week. She needs no introduction, but I was so proud to introduce Molly Sleigh. Molly, thanks for being here with us tonight.
Thanks for inviting me so much, Brenda. And thanks everybody for coming out tonight to learn a little bit about outcome measures for lymph and lipedema.
And with that, I will say, take it away and I will disappear.
Okay, thank you so much. Okay, so tonight our objectives are to identify 4 classifications of outcome measures utilized in clinical practice, describe the importance of clinical outcomes use for the treatment of lymph and lipedema, compare and contrast various patient-reported outcome measures with secondary lower limb lymphedemas. So when we talk about outcome measures, we can classify them into 4 different categories: performance-based, observer-reported, clinician-reported, and self-report. Performance-based measures require patients to complete some type of functional task, and scoring is usually done based on some type of objective measurement. The objective measurement might include the time that it requires to complete a task. Sometimes qualitative assessment is also used to assign a score, and an example of qualitative assessment during task performance might include normal or use of abnormal body mechanics while completing that task. And also physiologic factors can be identified while performing tasks during that performance-based measure. Some of the factors that might be reported on include tone, balance, weakness, or impaired active range of motion. Oops, I'm not advancing. There we go. Okay, so some examples of performance-based measures include the timed up and go test, which many of us are very familiar with as therapists. The timed up and go test is a performance-based measure of functional mobility that was developed to identify mobility and balance impairments in older adults. And the timed up and go tests uses the time it takes to rise from a chair, walk 3 meters, turn around 180 degrees, and come back and sit down in the chair. The 6-minute walk test is a submaximal exercise test used to assess aerobic capacity and endurance. And this performance-based measure looks at exercise capacity while walking 6 minutes on a hard, flat surface. And I know most of us have probably used these within the therapy clinic ourselves. Observer-reported measures are typically completed by someone that has regular involvement or regular contact with the patient, typically a caregiver or a parent. And it's a measurement based on a report of behaviors or events related to that patient's health condition. Some examples of observer-reported measures might include whether or not the client or patient forgets to turn off the stove. Can they remember where their keys are? Do they remember how to get to the store? Are they able to follow a recipe? What is their math ability when completing balancing the checkbook? Those are all examples of observer-reported measures. Just some more examples of observer-reported measures may include sequencing ability while getting dressed or putting on a stocking, for example. Sometimes those stocking donors are difficult to use, some more than others. So just looking at that patient sequencing ability, what is the level of agitation when completing a task? Those are all examples of observer-reported outcome measures. Clinician-reported outcome measures are typically completed by the therapist or the healthcare professional using clinical judgment and reports on behaviors or signs observed. Some examples might include the circumference measures that we take when calculating limb volume, assessing the skin. Is it dry? Is it flaky? Is measurement of wounds involved? Is there peau d'orange appearance of the skin? Is the stemersyme positive or negative in different parts of the body? Is there presence or absence of pitting edema? Those are all examples of clinician-reported assessment. So the final category is the category that we're going to spend the rest of our time on tonight. And those are self-reported measures or patient-reported outcome measures, sometimes referred to as PROs or PROMs. And self-report measures are important because they help to capture what is important to that patient. It captures their beliefs about their condition. It helps to objectify the patient's perception of their limitations. And typically, self-report measures are captured in questionnaire form. When we look at the effectiveness of self-report measures, we need to look at actually the definitions of the psychometric properties. And we're just briefly going to go through the definitions of each of these. They're important because when we use a test, it should have gone through a series of vigorous research studies that look at the effectiveness or intrinsic properties of each of these outcome measures. So validity looks at how accurately does a test measure what it is supposed to measure. High validity means that the measure is consistently stable in its ability to measure its intended focus. Inter-rater reliability with performance-based measures means that two therapists will determine a similar score on a performance that it's evaluated. It's consistency of results between two different evaluators of a common patient or subject. Intra-rater reliability for patient-related outcome measures looks at how consistently does that patient respond to the same result. Relevancy is with serial testing and no change in intervention. I hope I'm not boring you too much yet. with these definitions. I know we've all heard them before. Responsiveness is the ability of the measure to capture a change in status. Ceiling effect occurs when the test is too easy and does not capture that patient's full ability. And we see this when the majority of patients score within the highest range because the test is too easy. Floor effect occurs when the test is too hard or too difficult and lacks easier items to distinguish varying levels of status. So in this case, the majority of scores fall within the lowest range. The MCID is the minimal clinically important difference, and this is the amount of change that is relevant from the patient perspective, and it does indicate a significantly important clinical change. And for example, I know many of us are familiar with the DASH, disability of the arm, shoulder, and hand, and the MCID, I believe, of the DASH is 10. So why is it so important to use lymphedema-related patient-reported outcome measures? Why is this important? Well, it's important to use patient-reported outcome measures specific to lymphedema because they help to really capture disease-specific symptoms within the population, and they can be used along with other objective criteria or outcomes to really observe changes in that patient's condition. They serve as a tool into disease detection, including progression of the disease or actual improvement. And they can typically be easily applied to clinical practice. So unfortunately, there is not a great deal of literature that's been published on the validity of outcome measurements specific to lip and lymphedema. I wanted to highlight tonight the results of a study that was actually published in, I believe it was 2021, that compared 5 different outcome measurements specific to lip and lymphedema. The outcome instruments that were studied in this piece of literature were the SF-36, the FLQA-LQ, Freiburg Quality of Life Assessment for Lymphatic Disorders, the KOS-ADL, the Knee Outcome Survey for Activities of Daily Living, the SCL-90R, Symptom Checklist 90, and the 6-minute walk test. And I was most familiar upon reading this with the 6-minute walk test because this is something we commonly use in the clinic. The other 4 were, well, I was familiar somewhat with the short form 36, but these are typically outcome instruments that I had not seen a whole lot in the clinics that I had worked in. And it was interesting because the conclusions of the authors of this study indicated that all 5 instruments have strengths, and they went on to recommend that a minimum measurement set of all of these different parts of all of these different outcome measures should be used with patients in the clinic. And I read that and I thought, what? Wait a minute. How is that even possible? How does a therapist like me have time within 60 minutes to administer all these different parts of all of these different outcome measures to find out what's important to the patient? That just didn't make sense to me. So I thought there has to be a better way.
That is the best visual ever. That was not a selfie, was it?
No, it was not. Although I do look like that some mornings. That was not
me too.
That's funny. But that's how I felt after reading this study. So just doing some more reading and delving into things a little bit more deeply. In reality, patient-reported outcome measures for everyday practice in the clinic should be easy for the patient to fill out. It shouldn't take up a whole lot of your time. Your evaluation time is very important, and we have to use it effectively in order to fully assess that patient, get all the measurements we need, and also use the patient-reported outcome measure to help us set goals that are important to the patient. And they should also serve as a reliable measure to determine whether their condition is getting better or worsening with therapy. And that's why it's important to use a very specific, a disease-specific quality of life outcome tool. So once again, use of a limb-specific tool in addition to a disease-specific tool is very important when we're looking at lip and lymphedema, because there are very different patient-specific complaints between upper and lower limb lymphedema. It's noted in the literature that individuals with leg lymphedema are hospitalized more frequently with cellulitis, and they also report worse quality of life than individuals that have upper limb lymphedema. So that just illustrates the fact that there are differences reported between uppers and lowers. So it is very important to use, like I said, not only a disease-specific tool, but a limb-specific tool as well. So tonight, I selected 4 different patient-reported outcome measures that maybe most of us are unfamiliar with, just to kind of broaden our thought process and horizons, and maybe consider using a different type of tool to help identify what is important to the patient in therapy and what would their goals be. First is the PBIL, the Patient Benefit Index for Lymph and Lipedema, which was published in 2014. The PBIL can be used both in clinical and research studies. I like this tool because it does not use pre and post-test scores or differences. It's more of a direct measure of what the patient sees as relevant benefit to their treatment. And in gathering open item collection to develop this tool, patients with all different types of edema, well, primary and secondary lymphedema, as well as lipedema, were utilized. There are 2 parts to this outcome measure, which I find very interesting. The patient needs questionnaire, or the PNQ, which is filled out at the initial evaluation. And in the PNQ, the patient is asked to rate the importance of a list of specific treatment goals. So the patient decides what the treatment goals really should be, because they're able to identify which ones are important to them in the PNQ. The PBQ, or the Patient Benefit Questionnaire, is filled out then at the completion of therapy at the discharge visit. And in the PBQ, patients rate how well the treatment goals that they had identified early on in treatment have been met. This is a picture of what this particular tool looks like. And I really like this tool because completion of the PNQ helps the clinician to identify goals that are meaningful and important to the patient, not to me, but what's important to them. And I think really that's what it's all about when we're working with our patients. It's about what they see as important, helping them identify goals and helping them meet those goals with therapy intervention. The PBIL, basically, just to reiterate, uses a global score that's computed for each patient. There is a weighting, a logarithm that's used to look at achievement of treatment goals, as they will rank higher, have higher impact on the global score than achievement of less important goals. And what I like about this is that the retrospective assessment, the PBQ, helps prevent shift effects, because you may risk recall bias if patients do not recall the extent of their impairments prior to therapy and therefore make a biased assessment. So that's what I really, really like about this particular tool. The next tool we're going to discuss is the LGUCQ, the Lymphedema Genitourinary Cancer Questionnaire for Men, which was divided in 2014 by Noble Jones and her team. This particular outcome measure uses a 4-point Likert scale and asks for identification of the swelling, whether it's in the legs or the genitals. And it asks questions, including questions about skin. What is the effect of their condition on ADLs? Does the swelling get worse at the end of the day? Is there a need for pain relief or use of analgesics? Where is the area of discomfort? And it includes a picture of lower body and genitals and asks an open question about the patient's physical and emotional status as well. Over time, the LLGLQ, that prior outcome measure evolved into the LLGLQ, and there was one that was developed for men and one that was developed for women. The only difference from the previous one is that it had an extra question asking about the cause or the onset of the edema. This is a picture of what that looks like. And at the end, I'll give you links to each of these so you can download them and use them on your own. The next patient-reported outcome measure up for discussion is the LSIDS-L. I feel like I'm going to get tongue-tied with all this vegetable soup. The LSIDS-L, the Lymphedema Symptom Intensity and Distress Survey for the lower limb. This was developed by Sheila Ridner and her team in 2017. And actually, this is the most recently published patient-reported outcome measure specific to lip and lymphedema. And she and her team developed this particular outcome tool to really fill the gap between increased morbidity and symptom burden. The LSIDS-L includes 31 questions that are answered dichotomously. And if the answer is yes, there's a 5-point intensity scale rating that's given. And the questions are put together in 8 different clusters, including questions about overall activity, pain, sexuality. This is one of the few that asks about sexuality directly, soft tissue sensation, patient resource function, and neurological sensation. This is a picture of what that particular outcome measure looks like, 1 page. The next outcome measure up for discussion is the Lymph-ICF for the lower limb, Lymphedema Functioning Disability and Health Questionnaire for lower limb lymphedema. It's comprised of 28 questions with 5 different domains: physical and mental function, general activities, mobility, and social life. This is a picture of what that particular scale looks like, just one of the pages, one of many. And on this slide, I was able to pull up results of a study that was published in 2021 by Eidenberger and his team. And this was a systematic review of 6 different outcome measures used in the lip and lymphedema population. And 3 of the outcome measures that we just discussed were included within this study: the Lymph-ICF-LL, the LGUCQ, and the LSIDS-L. I know it's hard to keep all of them straight, alphabet soup. But I pulled this up because it did include 3 of the 4 that we just discussed. And if you look at the totals at the bottom, it looks like Ridner's LSIDS-L may actually be the most inclusive of all of these that were included in this systematic review. So just keep that in mind. If you're opening your mind to using a different tool in the clinic, the LSIDS-L may be highly inclusive of several different categories. So on this slide, I came up with 7 what I felt were 7 important key categories for comparison amongst the different patient-reported outcome measures. And I'm going to identify those, and then we're going to identify, of the 4 that we discussed tonight, which ones include each of these 7 important key categories. And those categories are psychological stress, edema and financial strain, skin condition, movement or range of motion, ADL, sexual function, and leisure activities. So if we look at the category of psychological stress, only 2 of the 4 that we discussed tonight really ask specific questions about psychological distress. And I think that this is really important because typically, if you look at the studies, when patients report higher levels of psychological burden or stress, it's because they lack knowledge about their condition. And I think that identifying psychological stress is important because it tells us how much they know about their condition and if we need to really work on coping skills in regard to their condition. So this kind of helps us see how much education we need to offer patients. Disease-related education or knowledge should be communicated with the patient by the therapist, because we know that having a better understanding of self-management strategies can definitely influence their stress level and also affect their outcomes. And that's documented in the literature. Looking at the category of edema and financial strain, this is important because financial strain is really a significant factor in health-related quality of life, because lack of funding or lack of funds could be a potential psychological stress factor. We know that it is expensive to care for lymphedema, to maintain limb reduction. There was a study that was published in 2017 that concluded that it costs roughly $977 per year is the average cost of managing breast cancer-related lymphedema. And that's high. And we all know that typically lymphedema is a lifelong disease process, so financial burden can be significant. So it is really important to look at financial strain as it relates to edema management. And Ridner's was the only one that did that. Assessing skin condition. The Noble-Jones LLGLQ was the only one of the 4 that asked questions about patient perception of skin condition. We know this is important because cellulitis episodes can worsen lymphedema status and lead to decreased health-related quality of life. So we know also that skincare is key to assessing their knowledge about and habits about prophylactic behavior, about taking really good care of that skin to avoid infection. But Noble-Jones's LLGLQ was the only patient-reported outcome measure to include questions about skin. Surprisingly, none of them asked questions about movement restrictions or active range of motion. And to me, this was really surprising because we all know that limb heaviness in the leg can definitely lead to active range of motion impairment. It can be a side effect of lymphedema and lipedema. And so I was just really surprised that this question was not included in patient-reported outcome measures, because it can affect the ability to perform ADLs independently and helps determine the need for assistance. So surprisingly, none of them included questions about this. Fortunately, all of them did include questions about ADLs, activities of daily living. Sexual function, which sex is an ADL. Only 2 asked questions about sexual function, and this was the Noble-Jones and Ridner PROMs. In addition, the Noble-Jones patient-reported outcome measure, the LLGLQ, included a drawing, actually a scale where the patient can shade in or draw in where they think that they have edema or swelling, which is helpful because sometimes patients are maybe embarrassed about verbally communicating that. So I think that the drawing maybe eases some of that nervousness or anxiety about conveying their symptoms. And Ridner's patient-reported outcome measure, the LSIDS-L, does ask direct questions about sexual function. Leisure activities, once again, Ridner, the LSIDS-L, and then DeVoot's Lymph ICF does ask questions about leisure activity, which is important to quality of life. So in conclusion, I would just like to really reiterate that using lipedema and lymphedema specific patient-reported outcome measures are important to capture that patient's perception of their disease. Inclusion of PROMs with objective data is very important, and it's especially important using these to identify goals that are meaningful, not to us, but to the patient, because that's what we're here for. We're here for that patient. We are here to help uncover or reveal what's important to them, because that should really be what our goals of therapy focus on, goals that are really meaningful to that patient and goals that will help improve what they perceive as improved quality of life. And deciding on the right tool will vary just depending on the location of the swelling and what the clinician or research focus is. This slide, which you'll get from Brenda in your email, includes the links to all of the downloads where you can download each tool and use it on your own. Here are my references. And I thank you very much for tuning in.
That was such a comprehensive overview, and I learned so much. I want to invite anybody who has questions in the Q&A to please put them there. We will address them. I'm still gobsmacked that there are no movement restrictions.
I know, that was really surprising for me because it's very common for patients with lower limb lymphedema specifically to have movement impairments based on the limb volume excess in their legs. So to me, that was really surprising.
Well, mobility is such a key function of life. I know with Lymphopress, we are all about helping people get back to living, and mobility is so wrapped up in that. By the way, we have so many lovely people saying thank you, Molly, Kath Houts, and Sandra Collins, and you've got lots of fans out there that are very appreciative of this information. But I mean, it almost seems like there needs to be another measuring method out there that includes the mobility.
I agree. So maybe we can all put our heads together. And
maybe one of my favorite minds just weighed in, Dr. Karen Herbst, who is our Chief Medical Officer. We're so glad that you're with us tonight, Dr. Herbst. And she asked this: what about pain? What's the best way to quantify that?
That is debatable. And there's been a lot of discussion and debate over all of the various pain rating scales that are out there. That's a tough one to answer. I know therapists with each therapy visit are required to ask, at least here in our clinic, and I'm sure it's the same at many others too, how would you scale your pain on a scale of 0 to 10, if 10 is emergency room pain and 0 is no pain? So it's hard whether you use like a visual analog scale where they look at the scale and they circle the face, or if they just give it a pain scale rating. So That's a tough one to answer.
It is a tough one. So then there's a follow-up question from Dr. Herbst. What about a goniometer? Did I say that properly?
I don't know.
For measuring joint mobility. And feel free to be in disembodied voice if you'd like to be, Dr. Herbst. You're welcome to just pipe in and talk. What about a goniometer for measuring joint mobility? So you've stumped us, Dr. Herbst.
Well, like, the Molly, the measuring tool that shows their ability to like bend their leg completely.
Goniometer.
Ah, thank you.
goniometer?
I've learned, class, I've learned a new word tonight, goniometer.
This thing.
Oh, I just had, she just happened to
Now,
have
if you're
one.
talking to, I'm still in the clinic here. I'm still at work. This is a goniometer. Yes. What about it?
I'm just thinking for like, I mean, maybe for measuring mobility and, it would be like you combine pain score with joint movement. I don't know that, I'm not a physical therapist and you guys do so much better job than I could ever do, but like combining things, a questionnaire plus some physical exam measure. I don't know if anyone does anything like that. It's kind of like having like a timed up and go as part of a test where you combine it with questions.
Yes. And I think a lot of us do use a variety of measures, including, I know I always take range of motion measurements, of the hips, of the knees, of the ankles, in addition to, circumferential measurements for volume, which isn't the greatest standard, but that's what we use here in our clinic for now. Coupled with, mobility testing, the 6-minute walk test. So I think it's through a combination of measures that we try to get a clear picture of how that patient is moving, what their pain is, what is their limb volume, looking at the skin condition, assessing the tissue also is very important. And I think, I really wanted to hit home tonight that selecting the best patient-reported outcome measure, really using one that is disease-specific and limb-specific is really important to help get a sense of what goals are meaningful to that patient. And I think that using the right patient-reported outcome measure helps us to do that more effectively.
Excellent. And I want to go to one other point that you raised, the psychological burden of lymphedema and lipedema. And I'm so glad you mentioned that because that's really been on our heart here at LymphaPress. We definitely provide pneumatic compression that helps people manage these conditions. And yet the chronic nature of these conditions takes a toll.
Yes.
How do you, just understanding it can help all of our wonderful therapists that are out here tonight that have logged on. And I want to say that LymphaPress truly appreciates all of you and the amazing work you do. We want to partner with you. We've tried to create some online communities with our roundtables to support the patient because it's not just about giving them a pump and saying, have at it. There's so much more involved.
You are absolutely right. And I think that's an area that oftentimes kind of falls by the wayside. I think that really giving them the tools they need. And like in that slide, I mentioned that in addressing psychological burden, the more tools we can give them to be independent, the more knowledge, that's going to help ease that psychological burden because they feel more in control. They feel like they have some power over their condition. So I think really looking at that and assessing that initially is important so we know how to move forward.
That is so good. All right, now I'm going to flip the script for just a minute because I'm looking at a lot of names out there, and these are people who are treating chronic patients. And I was toying with this idea recently. So there is the toll of dealing with a chronic condition, but what about the toll on the medical community that's dealing with the patient population who is depressed, angry, and frustrated and dealing with these psychological issues? I can only imagine that it is a drain on all of you too.
It has its challenges, but I also think that I can only speak to my experience and my what I've gone through with my patients. I think it's really important to really maintain a positive influence and try to make that patient feel good about moving forward with their therapy by giving them all the tools and the knowledge that they need, and just being a bright light for them.
Yes.
And most importantly, giving them hope, because I think a lot of patients come in, and particularly the lipedema population comes in, you know, they've been to 20 other professionals before they finally see someone that knows anything about lipedema. And they're tired, you know, they're frustrated. And I think giving them hope is extremely important. Extremely important.
Your heart for patients shines through in everything you say and do, and in your research. Janice Miller just said in chat, I appreciate you and your research. Thank you so much, Molly. For all of you who are logged on tonight, and for you, Molly, who give and give and give to make lives better for people, we do appreciate you so very much. And we at LymphaPress consider it an honor to partner with you. We consider our team to be an extension of your respective practices. You need help, support, advice, whatever. Our compression therapy consultants are there to stand with you and do the very best we can to give hope to these patients, many who are homebound, many who need at-home therapy, and that's where LymphaPress can make such a difference. And so I just thank you so much. Do you have any parting words that you'd like to share with our audience tonight?
Well, just always do your best. Do your best in the clinic. Do your best with your patients. And if you're always doing your best and trying your hardest, you can't go wrong.
All right, well, that is a perfect way to end tonight's webinar. Again, thank you, all of you. If you need information about LymphaPress, our website, lymphapress.com, or email me, bviola@lymphapress.com. Everybody who is on tonight or who has registered will receive a link to the replay and those valuable links. And thank you, Dr. Herbst, for being a disembodied voice on our call tonight. Dr. Herbst, is there anything else that you would want to add before we close out tonight?
I just want to thank Molly. I thought you did a great job. This is a really hard topic because it can be dry, but I thought you did a really great job and you gave lots of different options. And I think it's important for people to find an option that they like and to use it regularly, because patients forget how they were, you know, a week ago, a month ago, 6 months ago, and they say, you know, I haven't changed. And you can say, well, actually, look, we've got data showing that you've actually got better, because we all get on a new hedonic cycle wherever we are in our life. So again, thank you so much for this. I think this is a great resource, especially your links and your references.
Perfect. Thank you, Dr. Herbst. And thank you, Dr. Sleigh. And thank you, everybody, for joining us tonight. Have a great night. See you again.
Bye-bye.
Bye.
Bye.